Welcome to our Pit Crew CPR training module. It's put on by the Integrated Medical Services Office. We want to especially thank the crews from City Fire Department, Spokane Valley Fire Department, and American Medical Response in Spokane for their participation in making this training video possible. We're going to talk about Pit Crew CPR today. Initially, I want to go through some of the basic tenets of what Pit Crew CPR is. I think the most important thing to emphasize is Pit Crew CPR is more than just high-quality CPR. We all know that high-quality CPR incorporates quality compressions, and depth, recoil, etc. But how do we employ this is more of the concept of what Pit Crew CPR is about. It's a team approach that utilizes every member available with specific roles to give us a structured response to allow us to provide an efficient resuscitation. There's a prioritization of resources that are available. We all know that depending on the call, certain crews will show up before others. And the more time we spend on scene, more resources will become available to us. How do we best utilize the resources that we have, and how do we delegate arriving resources to help promote an efficient resuscitation? There is an order to this. It results in safer resuscitations, less risk of needle stick, and ultimately results in more successful resuscitations. The underlying component of this is that we are trying to promote a quality effort, a quality resuscitation that improves lives in our community. The first question you need to ask yourself as an individual or a team is, how well do we resuscitate? And we've all participated in highly efficient, successful resuscitations where things ran, quote, smoothly. We've all participated in resuscitations where they were sloppy at best. And you can see here in this diagram the premier examples of organized versus chaotic resuscitation. You can all ask yourselves, how well do I perform as a team in promoting either an efficient or a chaotic resuscitation? The major tenet of the pit crew concept is that we cannot control the environment that our resuscitation is taking place in, but we can control our response. An adequate and structured training ensures that our responses will result in higher quality, provider safety, a quiet and controlled effort, and ultimately improved outcomes. There are specific roles in our proposed model of pit crew resuscitation that must be filled. Position number 1 becomes a code team leader and is designated by the individual who arrives with a monitor and an AED. Position number 2 is your compressor. These two individuals would be the first employed providers on the scene of a resuscitation and take priority above all else. A dedicated individual at the airway makes up position number 3. A dedicated provider to the femoral pulse makes up position number 4. A provider available to obtain IV access or IO access if it is not yet available, and to manage the drug box makes up position number 5. And ultimately, a timer makes up position 6. As we go through these next series of slides, I'll try to create a picture that demonstrates in order of responding agents how to fill up these positions. The first arriving provider on scene will take up position number 1. It is imperative that they apply the AED pads or the defibrillator pads and perform a quick look to potentially defibrillate VFib or pulseless VTAC. We know that early defibrillation correlates with improved survival. Also important is that the monitor or AED be positioned in the immediate vicinity of the provider making up position 1. This becomes a priority position for the first ALS responder on scene. They will also position their drug box in their immediate vicinity and, if time permits, start an IV. Early epinephrine in non-shockable rhythms correlates with increased survival. And early IV administration requires intravenous access as soon as possible. Position number 1 becomes the code team leader. and should be introduced as the code team leader to all incoming providers. Position number 2 is the compressor. Their role is to immediately initiate high-quality CPR. They initially have the responsibility of being the timer with compression counting, and ideally letting the code team leader know when they reach 150, 175, and a countdown to 200 compressions for a rhythm check. As additional resources enter the scene, they can participate in the compression cycle. Position number 2 can also participate in post-ROSC procedures, specifically obtaining a blood pressure and attaching electrodes for a 12-lead EKG. Position number 3 is designated to the airway. Their role is to insert an NPA or an OPA and place a non-rebreather mask at 25 liters per minute, or the maximal flow that that device will allow. It is important that they position the airway box in their immediate vicinity, and they also position an O2 cylinder in the immediate vicinity. They can either insert a supraglottic airway or an endotracheal tube as instructed by the code team leader. Following placement of a definitive airway, a C-collar is also placed by this individual. It is imperative that they ventilate at 1 breath every 6 seconds for a total of 10 breaths per minute. Following ROSC, it is their role to monitor oxygen saturation and end-tidal CO2 levels. Provider number 4 takes a position at the femoral pulse. Their role is to monitor for compression quality and to provide rapid pulse checks to determine PEA versus ROSC at 2-minute cycles. It is also their role to hold the IV bag above the level of the patient to ensure that forward flow of drugs and normal saline occurs. Position number 5 should be an ALS responder or a provider who has IV skills. Their role is to obtain vascular access if it has not already been completed by the code team leader. Additionally, their role is to draw up and administer ACLS drugs as instructed by the code team leader.
9, 8, 7.
Position number 6 becomes a timer. Their role is to notify the code team leader at 2-minute intervals, to document and prompt ACLS drug administration at appropriate time intervals, and to supply the code team leader with the pre- and post-ROSC checklists when requested. As additional resources enter the scene, they can participate in the compression cycle, they can participate in evacuation and transport planning, or other tasks as designated by the code team leader. I want to take a moment to discuss the specific responsibilities and tasks of each of these providers. The code team leader may be a BLS or ALS responder depending on the initial response crew. However, it becomes a priority position for the first ALS responder on scene. It is imperative that they turn on the metronome to set cadence for the individual providing compressions. Equally important is pre-charging the monitor to minimize pauses during rhythm checks that occur at 2-minute or 200 compression cycles. This results in more timely administration of rapid defibrillation for shockable rhythms and early epinephrine in non-shockable rhythms, both of which are correlated with higher survival rates in resuscitation. Delegation of tasks allows the code team leader to focus on medical management, including rapid rhythm interpretation and review of the 5 H's and 5 T's in the resuscitation effort.
Ventilate.
The compressor may be either BLS or ALS depending on the available resources. Their priority is to ensure quality CPR. This includes a rate of 100 compressions per minute, 2 inches or 5 centimeter depth compressions, full recoil, and minimal interruption. The initial compressor becomes a timer until relieved by a timer at position 6. It is important for them to count down compressions, letting the code team leader know when they are at 100, 150, 175, and then ultimately provide a 15-second countdown at the termination of the 200 compression cycle.
2, 1, stop CPR. Patient's in VFib. Everybody clear.
It is important that compressors utilize a hovering position during transition between compressors. This allows for short peri-shock pause intervals and only brief pauses during rhythm assessment. High-quality CPR ensures that we are achieving adequate coronary perfusion, which correlates with ROSC. A well-perfused myocardium is more likely to experience return of spontaneous circulation. We know that 15 millimeters of mercury and above is associated with ROSC. Nobody achieves ROSC if they do not have 15 millimeters of mercury of coronary perfusion pressure. This is achieved by adequate rate, adequate depth, and appropriate recoil with each compression. Any interruption during chest compression leads to unwanted pauses and a drop in coronary perfusion pressure. Our target goal is designated by this bold red line at 15 millimeters of mercury. Each compression helps achieve a 15 millimeter of mercury or higher mark. A pause in compressions results in a drop of coronary perfusion pressure, and the next series of compressions requires a ramp-up time to get back to a level that we want at greater than 15 millimeters of mercury. This results in an exaggeration of poor perfusion during the resuscitation effort.
Ventilate.
Initial airway management includes an OPA or NPA with a non-rebreather mask at 25 liters per minute. This is a sufficient airway management technique in the first 3 compressions or 6 minutes of the resuscitation. During that time, a provider can prepare for placement of a supraglottic airway or an endotracheal tube as directed by the code team leader. If a more definitive airway can be completed within that 6-minute interval, that is also appropriate. It is imperative that the airway provider ensure slow, low-pressure ventilations at a rate of 6 seconds or 10 breaths per minute during the resuscitation. This provider monitors oxygen saturation and end-tidal CO2 levels, observing for washout. However, it is imperative that they do not hyperventilate to correct the elevated end-tidal CO2 associated with washout at the time of ROSC, as this can be detrimental for perfusion. The provider designated to the femoral pulse is quality control for our compressors. They will be able to distinguish between good perfusion and poor perfusion between providers, and they need to provide that feedback to the individual who is at the compression position. They also need to provide rapid pulse checks to distinguish ROSC from PEA when an organized rhythm is visualized on the monitor. Again, keeping the IV bag elevated above the level of the patient will ensure continuous flow of IV fluids and resuscitation drugs. The provider at the IV access and drug box position should be an ALS provider only, as they will be handling, managing, and drawing up ALS drugs. It may be the second or third medic on scene at the discretion of the code team leader. They will draw up and deliver medications as directed by the code team leader and provide verbal callback on all drugs and doses administered. This allows the code team leader to step back from the resuscitation tasks and focus on medical management. The timer notifies the team of 2-minute cycles and provides a verbal countdown at 15 seconds. This should prompt the code team leader to pre-charge their monitor. They should also be providing the code team leader with drug administration times and prompts, when adequate, for additional epinephrine as indicated. They, along with other providers in scene, can help obtain additional history from bystanders. As with any important response in fire and EMS systems, only adequate training and hands-on practice will ensure high-quality response. Interagency training is critical to success. Agency-wide training ensures a consistent approach and response regardless of individual personnel on duty. Our goal must be to practice until we cannot get it wrong. Routine feedback and immediate after-action review are critical to improvement. Our mantra of measure and improve is imperative to success of this program. All participating personnel should be receiving feedback regarding performance. This is an example of a CPR summary report. You can see the diagram indicates the average compression rate with a goal of 100 to 120 beats per minute. With the use of a metronome, we can ensure that we are reaching the appropriate target. The compression ratio indicates the time on chest, or time during the resuscitation that compressions were being performed. The goal is to remain above 90%. We can achieve this goal by minimizing interruptions, by having short peri-shock pauses, and prompt pulse recognition by the femoral pulse provider. This is a breakdown of that summary, indicating pauses and compressions that demonstrates appropriate peri-shock pauses and can identify unnecessary pauses or excessive pauses. I think it's important as we approach pit crew CPR to discuss the important role of quality resuscitation. The number of people who die each year from sudden cardiac arrest is roughly equivalent to the number that die from Alzheimer's disease, assault with firearms, breast cancer, cervical cancer, colorectal cancer, diabetes, HIV, house fires, motor vehicle accidents, prostate cancer, and suicides combined. Let's look at the number of deaths caused by fires in 2014. Fires caused 3,275 civilian deaths and 64 line-of-duty deaths in 2014. That's one civilian fire death every 2 hours and 41 minutes. If each home had a smoke alarm that worked, we could save an estimated 890 lives annually. And if we employed smoke alarms and sprinkler systems throughout, we could potentially reduce fire deaths by 80%. 2,620 potential lives saved. This is a noble goal. And we've seen throughout EMS training the benefit of an organized, structured approach to fire and the benefit that it provides our citizens in terms of our rescue efforts. Let's take a moment to look at American Heart Association sudden cardiac arrest statistics. Nearly 326,000 out-of-hospital sudden cardiac arrests occur annually. Out-of-hospital cardiac arrests have a survival rate of approximately 10%. That's greater than 32,000 potential lives saved annually. Approximately 20% of out-of-hospital cardiac arrest victims have an initial rhythm of VFib or pulseless VTAC, which confers a 28% survival rate on average. Spokane County has consistently exceeded these national statistics. The implementation and training of an effective and organized strategy for resuscitation will save lives also. We've seen the benefit and the success of lives saved with robust fire training programs in the previous slide. Why would we not employ that same strategy in our response to out-of-hospital cardiac arrest? I'd like to take a moment to review two examples of well-run resuscitations via the pit crew training model. In the first resuscitation, we'll see a patient who suddenly collapsed, whose initial rhythm is VFib on the monitor.
Hello, what happened today?
Just in the classroom and he was complaining of chest pain and a drum. Checked for a pulse, did find one, so I started CPR
Okay, how long you been doing CPR?
for about a minute.
Okay, 1 minute. Count to 200.
Got it.
Jesse, let's get a King Airway place as soon as we can on this patient, please.
Ventilate.
I'm going to do a quick rhythm interpretation. I'll do a countdown timer.
Notice that pads are attached without a pause in compressions, allowing for a rapid initial quick look for a shockable rhythm.
Ventilate.
Pulse here. Okay, I'm doing a countdown timer, guys. 15,
15, 14.
By pre-charging the monitor, we ensure
11, 10,
that there is minimal
9,
pause at
8,
the time of a rhythm
7,
analysis.
6, 5, 4, 3, 2, 1. Stop CPR. Patients with VFib. Everybody clear. Shocking patient. Start CPR.
Sean, this is spoken in
Count to 200.
Third person with one medic.
Okay, I want you to take over starting an IV and medication administration.
Ventilate.
Dale, will you take over femoral pulse, and then you'll be holding the IV bag.
Ventilate.
And next on compressions, please. Rotation.
As
in.
additional resources arrive on scene, you'll notice that they introduce themselves as well as the level of providers they bring to the
Yeah,
resuscitation.
we're probably about 50 compressions into it, and then you'll take over timing responsibilities.
Ventilate.
We've delivered one shock, patients in VFib. Effective bystander CPR when we arrived on scene.
Ventilate.
Entitled. Let's get someone to, Travis, will you auscultate for the lung sounds for this King Airway, please?
Ventilate.
You got good end tidal CO2, Jesse, at 45 right now.
Got nothing there.
Ventilate.
On the
Ventilate.
right. Good on the left.
Okay, we got a King Airway place.
Ventilate.
Securing it this time, we'll put a C-collar on. Got good end tidal at 45.
Ventilate.
150.
SpO2's at 90. And whenever you can, we'll be giving epi. Whenever you get the IV started, please. AMR here. I'd like for you to get a blood sugar, Andrew, and then let's start going through the pre-RUS checklist.
175.
Ventilate.
Kate, will you start thinking about how we're going to transport this guy out of here? Come up with a packaging plan, please.
Ventilate. Ventilate.
We got an 18 gauge in the left AC.
We're at 200 engaged.
200. Okay. BC's taking over timing responsibility, so you don't need to count anymore. How far are we into the timer, Brian? Just you're going to take over next rotation, right? Okay, everybody, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Stop CPR. Patients at VFib, everybody clear. Shocking patient. Start CPR.
199.
Okay, 1 milligram epi, Brian. You got timing responsibilities. Let me know when it's been 3 minutes since this last epi.
Ventilate.
Camera's 99 too.
Ventilate.
Could we get the pre-RUS checklist?
Once the timer is available, they will assume timing responsibility at the termination of the compression cycle that's in process.
And Kate, could you hook up ECG for me, please?
Doesn't appear to be any signs of hypoxia.
Ventilate.
We're treating any hypoxia right now. We'll consider some bicarb for the
Ventilate.
acidosis a little bit later.
Okay.
Check the glucose is normal.
Ventilate.
Okay, it's a 12 lead. No signs of hypothermia. Possibility of toxic tablets.
Ventilate.
Doesn't appear to be any taphamod. Let's consider our thromboses.
Ventilate.
Possible MI or PE.
Okay.
And doesn't appear to be any trauma. 1 minute.
Okay, sounds
The
good.
designation
And,
of
we'll
tasks
get
to
to
providers on scene allows the co-team leader to focus on medical management during the resuscitation.
Ventilate.
A review of the H's and T's allows them
Brian, let me
to
know,
identify
3 minutes.
and
Ventilate.
potentially
We'll give
correct
another
any
100,
reversible
please.
causes of arrest. Your H's and T's
Ventilate.
include hypothermia, hypoxia, hydrogen ion acidosis,
30 seconds.
hyperkalemia, hypovolemia, and hypoglycemia. T's include
Ventilate.
toxins, thrombus, pulmonary embolus,
Ventilate.
thrombus, myocardial infarction, tension pneumothorax,
Ventilate.
Pre-charging.
pericardial tamponade,
6, 5,
or other
4,
traumatic injuries such as
going.
head injury.
Keep going. Stop CPR. Everybody clear? Patients in VFib, shocking patient. Start CPR. How far are we into from that last epinephrine?
Ventilate.
1 more minute, okay.
Ventilate.
Good bagging, Jess?
Good bagging.
Okay. And we got a good pulse down there, strong pulse?
Ventilate.
Due for your next epi.
Ventilate.
1 milligram epi.
130.
Ventilate.
Let me know 3 minutes from that epi, Brian, please.
Ventilate.
Clear communication between the ALS provider at the drug box,
Ventilate.
the code team leader, and the timer who is documenting ALS resuscitation efforts is imperative.
7,
Recharging.
6, 5, 4,
Ventilate.
2, 1.
Stop CPR. Asystole. Start CPR. I'm dumping the charge.
It is important that the code team leader is capable of making rapid rhythm interpretations.
So patient weighs
In this
approximately
instance,
100 kilograms.
asystole was
So let's give them
identified,
100 milliequivalents
which
and
does
let
not
it back up.
warrant defibrillation or a pulse check.
Ventilate.
Had an organized rhythm been identified, then a rapid pulse check would have been requested.
Ventilate.
Looks like we've had washout on end-tidal CO2. End-tidal CO2 is up to 50 right now, so make sure we're really vigilant on that pulse check during the next rhythm interpretation, please.
Ventilate. Ventilate.
Will someone check our O2 cylinder, make sure we have enough
Ventilate.
O's left, please? Will you do that, Kate?
Really
Ventilate.
good for now, but I've got another one I'll grab.
1 minute.
1 minute.
Ventilate.
And how long since the last epi?
Yeah, 1 more minute.
1 minute.
Ventilate. Ventilate. Ventilate.
You're due for your next epi.
Okay, 1 more milligram of epi.
Ventilate.
We're at 30 seconds.
30 seconds.
Ventilate. Ventilate. Ventilate.
At the completion of this 2-minute compression cycle, an organized rhythm warranted a pulse check.
Ventilate.
7 coming in.
Because we had a
Make sure we hold on
provider
to that pulse, please.
specifically assigned to the femoral pulse that was able to be completed in a
Okay,
timely manner.
stop CPR.
Had no pulse been felt, a
we have a
return to
pulse?
compressions as soon as possible
Okay.
would have been
Looks like we're in atrial fibrillation, dumping the charge. Let's do a 12 lead, please. And let's get a blood pressure, shutting off the metronome.
Ventilate.
Keep ventilating the patient at 8 to 10 a minute, Jesse.
shortly after
Turn
Ross
on the VFib,
will ensure quick
VTAC
identification of myocardial infarction
alarm. And could I
and
see
alert
the
our
post,
statewide
Ross
triage
3-minute check?
designation system.
Okay, you'll be staying on that pulse for 10 minutes. Just keep looking at the monitor, determining if the rhythm starts looking bad. Just let us know if that pulse starts getting weak, please. Doing a 12 lead at this time. Obtaining a blood pressure. End-tidal CO2 is 45 right now, so just keep at your normal 8 to 10, Jesse. SpO2 is 94%, Brian. We got a C-collar placed. And we'll consider placing an endotracheal tube.
Ready for that 12 lead.
In presumed cardiac causes of arrest,
So
a
guess the
10-minute
patient's
timer
approximately 15
ensures
years old.
that the patient is appropriately packaged, that oxygenation and ventilation is appropriately managed, that post-resuscitative hypotension is adequately treated, and that an EKG is obtained to ensure adequate identification of potential cardiac causes of arrest. In this second scenario, we'll see a patient who arrests
He was complaining of
primarily
difficulty
from
breathing all day.
respiratory
Went out maybe about 5
difficulties.
minutes to breathe it.
Their initial rhythm
And,
is
back in and
PEA,
called
a
911.
non-shockable
Dispatch
rhythm,
told me to start
at
CPR.
which time early epinephrine, as opposed to ventricular fibrillation, is the preferred initial management.
Respiratory disease,
Yeah.
is that correct?
Correct.
Ventilate. Ventilate.
Get him to Travis, just set me up a line, please. Jesse, you
Ventilate.
heard the underlying history of respiratory disease? Yep, I did. I'm gonna do a
Ventilate.
countdown timer in a sec.
Initial airway management includes placement of an OPA and a non-rebreather mask of 25 liters per minute. In this instance, the code team leader is requested that
12,
the medic at the airway
11,
position
10,
perform endotracheal
9,
intubation.
8, 7, 6, 5, 4, 3, 2, 1. Stop CPR. Organized rhythm, no pulse. Start CPR. Dumping charge.
Sean, this is Spokane Engine 14. I'm 3-person with 1 paramedic.
Okay, Jesse's
Ventilate.
doing innovation. I'd like for you to take
Upon the
over.
arrival of additional resources, they adequately introduce themselves again, identifying the capabilities of each provider they bring to the resuscitation.
Just make sure we're
In this circumstance, it's a 3-man team with 1 paramedic and 2 BLS providers. The code team leader quickly designates those additional resources to critical positions, including IV access and medical box management, ephemeral pulse, and an additional compressor into the rotation.
endotracheal intubated the patient.
Yep, I saw it pass the goal before.
When the timer arrives on scene, he's given a brief summary of the resuscitation at its current state, the medications that have been delivered, how many cycles of CPR have ensued, and instructions to take over timing responsibilities at the completion of the current compression cycle.
Ventilate.
What size tube, Jesse? Okay. Jesse, what size tube? Tube's good.
Ventilate.
Okay, you got good cap, yep, good capnogram, positive waveform. Vital right now is 30. We'll give 1 milligram of epi whenever you get around to it.
We're ready for epi, early epi for initial non-shockable.
Ventilate.
Correct.
AMR's on scene, how can we help you guys?
EMR,
Ventilate.
let's do chem strip on rail real quick.
175.
And then will you go over the
Ventilate.
pre-cross checklist and make sure we're not missing any H's and T's, please?
Sure.
Ventilate.
Here again, you see the importance of reviewing the H's and T's during a resuscitation. Again, allowing the designation of tasks and freeing up the code team leader provides them with ample time to focus on medical management. In this specific incident, the code team leader has designated the review of the H's and T's to an additional ALS provider on scene.
4, 3, 2, 1. Stop CPR. Any pulse? No pulse? No pulse. Start CPR. Dumping charge. Still in PEA.
Ventilate.
Kim is 82.
Nathan, let's open that up. Let's give a fluid challenge, please.
Initiating a 500 milligram per milliliter fluid bolus.
So thinking about our H's and
Ventilate.
T's, guys, we've got hypovolemia.
Okay, we've taken care of that now.
Yep. We've got hypoxia.
Ventilate.
We're doing some good oxygenation.
Got good compliance.
Hydrogen ion acidosis.
Ventilate.
We thought about giving bicarb eventually.
We'll contemplate that later on.
We just rolled out
Ventilate.
hyperglycemia or hypoglycemia. Hyper and hypokalemia.
Ventilate.
Any about history? Any renal history?
So, a significant history of underlying respiratory disease.
Ventilate.
Moving on to our T's, we have tablets, toxins, and tricyclics.
Ventilate.
Tamponade,
Nope.
tension pneumos,
Nope.
Ventilate.
pulmonary thrombosis,
1 minute. Okay.
coronary thrombosis.
Ventilate.
And then any trauma.
No signs of trauma. Thank you.
Ventilate.
Real fast.
What's that?
Not the 4-lead real quick.
Yes, please.
Ventilate. Ventilate.
Chief, how long has it been since the epi?
2 minutes.
2 minutes.
Ventilate.
We're at 30 seconds.
30 seconds.
Ventilate.
I'll be coming in on your left. Okay.
Ventilate.
And bystander, has the patient been sick recently?
Not that I know
ventilate,
Okay. And if you could find us a list of medications, that'd be great.
Sure.
Pre-charging the machine, guys.
5,
Remember to stay on that pulse.
3,
ventilate,
1.
Keep going. Stop CPR. Do you have a pulse? No pulse? No pulse. Start CPR. Dumping charge, still in PEA.
ventilate,
We're almost ready for another epinephrine.
Yep, we're ready now.
ventilate,
Good pulses with your compressions.
In 1 minute.
1 minute.
ventilate, ventilate, ventilate,
You want to lift them straight up in the air if we head towards that
Yeah, if we do
for
that,
a
it'd be
packaging plant.
ventilate, ventilate,
30 seconds.
You coming in on your left?
ventilate,
You'll notice that the strategic placement of the monitor, the drug box, the airway box, and the O2 tank prevents any unnecessary
ventilate,
reaching for items that are out of the provider's immediate vicinity. This provides an efficient workflow and an organized resuscitation.
4,
ventilate,
Compressions.
2, 1.
Keep going. Stop CPR. Asystole, start
At
CPR.
the completion of this compression cycle,
Dumping charge.
an organized rhythm was identified on the monitor, but no pulse was palpable. Having a designated provider on the femoral pulse allows for a rapid pulse check
ventilate,
when requested and the resuming of CPR with as minimal pause as possible.
Again, Chief.
The provider at the femoral pulse is holding the IV bag above the level of the patient, ensuring forward flow
ventilate,
and adequate administration of normal saline and resuscitation drugs.
ventilate, ventilate, ventilate,
9,
Pre-charging.
8, 7, 6, 5, 4,
ventilate,
2, 1.
Stop CPR. Do you have a pulse, Dale?
We do have a pulse.
Okay, stop compressions. Dumping charge. Let's get a blood pressure real quick and
Ventilate.
start packaging the patient for transport.
I hope these two videos demonstrate for you the importance and value of the pit crew philosophy. As you can see, designated roles lend to an efficient resuscitation effort. You'll notice that defibrillations were delivered as early as possible when advised, and chest compressions had a minimal amount of interruption at the end of a 2-minute cycle. These are critical for successful resuscitation. The organized approach lends to a more efficient, streamlined effort. Teamwork is critical, and training of this model will be absolutely necessary to see its success in the field. I appreciate your time and your effort, and I look forward to hands-on training sessions in the future.